Yes, Sonu, go ahead.
Very good morning, and I'm really thankful to Dr. Namrata Sharma and the IOS for giving me this opportunity. And what a wonderful morning when I'm talking in front of my guru. Thanks, Dr. Abhay Vasavada, who has always been telling us, teaching us, Dr. Ammar Agarwal, Dr. Mahipal, Dr. TL. Thank you so very much for giving me this opportunity. So I'll be talking on scratch and scrub. So this is all about managing tough PC plaques. So I think I would lay my case what Arup had left, and these PC plaques something sometimes could be very annoying. So I do not have any financial interest. Posterior capsular plaques or PCPs can cause visual disturbances. They at times may not be amenable to YAG, and too much manipulation can cause a PC tear. Now, this is very important, specifically when you're dealing with premium lenses. So, in an era where we are doing femtocataract, we are using online OCTs, and we are dealing with premium lenses, trifocals, multifocals in EDOF. And when we are giving patient this PCPs and post-operative dissatisfaction, that is very annoying. And specifically in high myopes, young aged cataract patients, and silicon-filled eyes, these PCPs could attribute to a lot of patient dissatisfaction. So, what I have observed for the last 150 patients that we've been doing, thick, thin PCPs, which are densely, or as Dr. Arup said, are an integral part of the posterior capsule, could be really visually disannoying, and or they are gelled with the posterior capsule. So what we plan is an initial separation of the PCP using the microrhexis forceps. So by the scratch technique to scratching to get the edge separated and then peeling them very carefully, as has been described in literature by multiple publications by Dr. Abhay Vasavra himself, Dr. Namrata Sharma, and various other publications, very carefully, circumferentially or radially, and maintaining an adequate cohesive visco in the AC just to flatten. Now, this is very important, which I want to lay. A cohesive viscoelastic creating just a flattened posterior capsule is a key to prevent the inadvertent PC tear. So let's see how I deal. So two of my videos here show these posterior subcapsular cataract, and these posterior subcapsular cataract had those PC plaques. So this is a quick phacoemulsification, what has been taught by Dr. Vasavra and what we have been doing all these days, a good round regular capsular excess, a quick phacoemulsification in these patients. I would just zoom it to 2x. So this is the main port incision, a good hydrodissection, which is important, and a quick phacoemulsification using the stop and chop technique, separation here, holding, separating, and eating and gulping away. So these PCPs at times can be separated using various techniques described in literature. So what we came out was when these PCPs are strongly adherent to the posterior capsule, it's difficult to separate. Now watch. This is the irrigation action which I take. I use an polish always in my practice. I try to shine my posterior capsule very carefully. I am able to separate most of the debris on the posterior capsule. Now watch. This is the PCP that I'll be talking about. And if you see, it's right there on the visual axis. There goes in my microrhexis. I have put a liquid viscoelastic just to flatten the PC. Now, the moment the PC becomes a little convex or concave, you are bound to have a PC tear. So these folds, the folds that you see on the PC are an indicator. The moment you see these PC folds, you need to push in a little viscoelastic, flatten them, and then start scraping. So by scraping, what I'm trying to do is I'm separating on either sides this PC plaque, which is very, very adherent onto the posterior capsule, which otherwise would not be amenable to polishing whatever way we might have done it. So very carefully, I'm trying to scrape using the forceps, and this is where viscoelastic goes in, flattens the posterior capsule again. And now with this rhexis forceps, I'm able to just peel them off because I can get an edge on either sides of these plaques. So hold, leave, and very, very carefully, you have to note the posterior capsule, the folds, the radial or circumferential, just to prevent the inadvertent, just watch these folds, just to prevent any inadvertent posterior capsular tear. So when you're doing this, all these maneuvers, you have to have an hand in hand a vitrectomy, and you should be very, very careful. If you have a break, you need to convert them into a posterior capsular excess, because then only you can have a stable lens back complex. And this is how the picture in TROP looks like once you've cleared the PCP. And there is where you can have a satisfied patient. Yet another patient where we have some element of a polar and a posterior subcapsular cataract, and taught by Dr. Tial. In all these patients, we routinely perform a preoperative OCT just to check out whether there could be any break in the posterior capsule. So the viscoelastic goes in an adequate size capsular excess. And yes, this is a young high myope patient. So we have to be very, very careful. A good hydrodissection, and it's a very soft cataract. So it gives me challenges here. So I'm able to do separate 360 degrees and gulp away the soft, the nucleus. And now watch very carefully once we have removed this posterior subcapsular with some polar element cataract, and here stands the plaque. So very carefully, since the patient being a high myope, I use this irrigating polisher, and I'm trying to scrape. So most of the part goes off, but then again, this visually disannoying plaque sits in the center. So very careful to scratch, push in viscoelastic. Though most of my visual axis has been clear, but still the patient being a high myope, I have to be careful both ways not to create a break in the PC, and at the same time, I'm trying to scrape. So this is again an integral part of the posterior capsule. So I'm just trying to scrape and trying to create edges on either sides. And once I have these edges, I can then gradually lift and just peel them off. So it's a mix and play of a good viscoelastic, a balance between the instrument and the chamber pressures. And that is where, you can just carefully deal with these tough plaques and give patients an adequate post-operative outcomes, specifically when you're dealing with premium patients and premium lenses. So this is where a very gentle scraping I have done. Again, I would push in some visco, and then either using this irrigation aspiration, I can just lick it on from the posterior capsule. And then in these high myope patients, you can have a fairly good outcome despite these tough posterior capsular plaques. Thank you so much.
Thank you. Thank you.